Okay, we're going to go ahead and get started. All right, can you all hear me? Yeah? All right, good. We're going to get started. Okay, so today we're going to be talking about morbidity and disability a bit. Okay, so morbidity is any departure, subjective or objective, from a state of physiological or psychological well-being. So what's an example of morbidity? We've all experienced lots of morbidity in our lives, yes?
Bad headache.
A bad headache, exactly. Another example?
Depression.
What? Sorry?
Depression.
Depression, yeah, that's another example. Okay. Disability is any temporary or permanent reduction of a person's capacity to function. An example of a disability. You break your leg, right? Okay. Another example, something that's counted in for disability, believe it or not, is having to spend 2 days in bed, right? That is considered a disability. It's temporary, but you can't go into work because you've got, the flu or malaria or something like that. Okay.
But then the overlap between morbidity and disability, if you had the flu,
So if you have the flu, morbidity is like I had an episode of the flu, and my disability would depend on the severity, right? I might have spent 3 days in bed not going to work. I might have actually had to be hospitalized. So those things are measured in different ways and given different ways. Yeah, so typically any illness is a bit of both. Okay, so we've got incidence we're going to be covering today, prevalence, hospital discharge rates, that's an example of morbidity and/or disability, number of hospice visits, consultations, bed disability days, okay, work loss days, and restricted activity days. So some measures of healthcare utilization are like the number, rate of hospitalizations, outpatient visits, length of hospital stay, are of importance in healthcare utilization, health policy, and health economics research. But they're really kind of limited value in epidemiologic research, okay? So incidence is the frequency of development of a new case or occurrence of disease in a population over time, okay? So you're a new case of leukemia, you're a new case of influenza, new case of diabetes, okay, the first time that you've been diagnosed with diabetes. In order to measure incidence, people have to be followed over time, all right? Otherwise, you don't know that it's actually a new case. It could be a chronic case of a disease. And it's usually expressed as either a rate, okay, and we'll be talking about the incidence density rate today, or a proportion, which is the cumulative incidence. Okay, so cumulative incidence is the number of new cases during a specified time period divided by the number of disease-free subjects at the start of follow-up. All right? And it's got a range of 0 to 1, so that tells us it's a proportion, right? Okay? Incidence density rate is the number of new cases, once again, divided by the person time. And we'll talk quite a bit more about person time today in class. And the range of incidence density rate is from 0 to infinity, right? Because it's not a proportion, it's a rate. Yep. Cumulative incidence of death over everybody's lifetime? 1, right? Eventually, everybody will die. The cumulative incidence, if you were just talking about the first time that somebody got flu, would probably approach 1. There are probably some people who will never get the disease. Yes? No, the start of follow-up is when you start watching the people. It's actually, for a study, it would be the beginning of a study. Okay. So if I'm going to look for cases of breast cancer, first-time incidence of breast cancer, okay, in women, who would not be at in my study? Who's not at risk for being the first-time case of breast cancer in a woman? Men, right? They're not at risk in that group. Who else? People who have already had breast cancer, exactly. Okay, so cumulative incidence, the definition, the kind of word definition, is the proportion of a population at risk of getting a disease that become diseased over a specified period of time. Okay, so you could talk about the cumulative incidence over a year, over 5 years, over 10 years, okay? Over 5 months. So an example of cumulative incidence and how you calculate it is if you have 4,000 children that are observed for 2 years, and over the course of that should say 2 years, 1,600 children get influenza. What would be the cumulative incidence for that? So remember, the cumulative incidence, right, is equal to the number of new cases over the population, so over the number of people. Yeah, 1,600 over 4,000, or 40%. And then you would say over a 2-year period. You should try to specify the time period. We good with that? Yep. Okay. Okay. So incidence density rate, we already showed the formula before, but it's another way of looking at incidence, of measuring incidence. Okay, so now we've got the number of new cases of a disease, and instead of saying the number of people here, right, we put the person time. That's the amount of time that your population was observed for, and it's a true rate. Okay, so now we have the same problem, okay? We have 4,000 kids. We follow them for 2 years' time, and they contribute 7,892 person years. And over the course of that time, 1,600 children get influenza. So now we have, right? How many cases do we have? Yes? Yeah, I'm sorry. I changed the problem a little bit just to highlight that it doesn't have to be over a year's time. Okay, so 1,600 new cases still. What's going to be on the bottom here? 7,892, right? The number of person years. So if you do that, that's cumulative incidence there, right? We get 0.203 cases per person year, all right? Doesn't necessarily mean a lot, right? That's kind of a weird number. So you could also say, multiply it by 100 and say we get 20.3 cases per 100 person years, all right? Or you could multiply it by 1,000 and say that we get 203 cases per 1,000 person years. That's correct. Yeah. Assuming that the incidence stayed the same as in this particular study. Yes, that's correct. This is just kind of making it a little bit easier, and then we'll actually talk about calculating person time in a moment. Okay, so incidence in open populations and public health settings, we often talk about like the incidence of breast cancer and Marin, right? You have a higher incidence. Okay, so the numerator is the number of new cases, and the denominator is the mid-year population. When else did we use the mid-year population? What measure did we talk about last time in class where we used mid-year population? Mortality rate, right? Okay, it's very common in surveillance public health settings, the mid-year population. So it looks like cumulative incidence, looks a lot like cumulative incidence, right? But it is technically, it's considered an incidence density because those in the population all those in the population are assumed to be at risk, and each contribute 1 person year of time. So when you're calculating incidence at the population level, so community, okay, we could talk about the people in Temescal, the county, Alameda, state, California, country, the US. Really, we actually don't make any effort to exclude the people that are not at risk. And the reason for that is, what do you guys think? It's just, yeah, it's just way too difficult. And you're talking about a lot of people, okay? Probably most of them are at risk. And it's not going to make a big difference anyways. But it's just very difficult to enumerate that. And so we don't do it, okay? So, all right, so the census or a similar source of information about the total population in an area is what is used as the denominator. Okay, so the example here is the incidence of cervical cancer among women in San Francisco would be the number of cases divided by the mid-year population of the number of women per year. It's not as accurate, right? There are going to be some women who have already had cervical cancer, who have had a hysterectomy, so therefore could not have cervical cancer. Okay, so it is going to be not as accurate as it could be. We'd still call it a rate. It is, but it's just it is the way it's done. Okay, so a cohort, okay, is a designated group of persons followed over a period of time. All right, how many people are first-year MPH students this year? Okay, you guys are a cohort, right? I had my cohort when I went into my PhD. Is anybody in here born in 1980? Okay, you guys are a cohort, right? So that is the idea of a cohort. Okay, so you're followed over a period of time, generally to study morbidity or mortality. Okay, so a cohort study is a study that takes a group of people and follows them over time. And the group of people could all be enrolled at the same time. We could enroll new people each year. That doesn't matter. Okay, it's still a cohort study. So that's this idea of that it can be closed or open, so dynamic. So a closed cohort is a cohort with fixed membership. Once you define the cohort and you start follow-up, nobody else is added. Okay? The number of individuals followed over time is going to decrease naturally due to deaths, due to loss to follow-up. That means I enroll you guys all in my study. Next year I try to contact you. A bunch of you have moved, left no forwarding address. I can't find you. You're lost to follow-up. And also the development of the condition under study. But that actually kind of depends. That's this kind of, yeah, I don't do that because I do infectious diseases that you can have more than one time. Kid gets flu, not kicked out of my cohort, right? So that is disease specific, but generally a majority of cohort studies are following people to the first occurrence of disease. Okay, so some examples, classic examples of cohort studies are the Framingham Heart Study, the British Physicians Study, the Nurses Health Study, okay, the San Francisco Men's Health Study. You guys know what the San Francisco Men's Health Study studied? No. HIV, AIDS, right, in the 80s. They actually did something which caused a lot of things to change for people like me. So they promised health care for the rest of the participants' lives to everybody that participated in the San Francisco Men's Health Study. The study was funded by the NIH, the National Institutes of Health. So the reason they promised that, in part, was because they didn't actually think that people were going to live all that long, right? People were dying very quickly of AIDS, okay? Antiretroviral therapy came out. People lived a lot longer. There's still people who are getting all of their medical care paid for by the NIH through the San Francisco Men's Health Study. And the NIH made a new rule that they are never going to do anything like that again. So even if something is caused, like if you have an adverse event, happens because of the study, okay? We take blood from a kid's arm in our study. The kid gets septicemia. He actually has to have his arm cut off, okay? The NIH now says, we're not responsible. We're not going to pay anything for it. You know, that's kind of your own problem, which is unfortunate, but it's the way it is. You do, yeah, and they make the universities, like Berkeley has insurance to cover the immediate cost of the healthcare, but not any kind of long-term healthcare. So an example of a cohort study, this is a closed cohort, is the British Physician Study, often called the British Male Physician Study. Not true. There were women enrolled into the study. They just never published any results, okay? So they did it in 1951, males and females. Why do you think they never really published any results for female physicians? Yeah, because it was 1951, right? There weren't that many female physicians, so they didn't have very many findings from it. Okay, so they had 40,701 people who responded to the first study, to the first survey. Okay, that was it. That was their cohort. They never enrolled another single person. And it's a very famous study because it provided evidence that smoking caused lung cancer and a variety of other cancers. So an open or a dynamic cohort is a cohort to which new members can be added. And an example of that is the Nurses' Health Study. Okay? It's a cohort study of approximately 122,000 female U.S. nurses, and it was started in 1976. So every year, or for quite a while, they allowed for new nurses to enroll, okay, at age 30. So once you hit 30, if you were a nurse in the U.S., you were eligible to enter into the study. So the original question that the Nurses' Health Study was asking was, what are the long-term consequences of oral contraceptive use? But it's really provided a wealth of information on risk factors for chronic diseases for women. Okay, so population at risk, we've already kind of touched on this a bit. So, right, people who've already had the disease are not at risk, depending on the disease you're studying. Okay, and they're typically, you try to screen those people out, all right? If you're studying the first occurrence of cervical cancer, you don't want people who've already had cervical cancer because you're no longer considered at risk. Some infectious diseases, everybody, you know, if you can get a disease multiple times, then everybody would be considered at risk and you wouldn't exclude people. So another example, women who have undergone a hysterectomy, right, would be excluded. And then, so there is this kind of like little technical thing that some people will never get a disease. They're not at risk for getting a disease. Something about their genetics, they're immunologically protected, and they're typically, you know, they're truly not at risk. But we can't identify them, so we don't exclude those people. So you always have some number of people in a study, or potentially have some number of people in a study that are technically not at risk for the disease. Okay, so this is an example from Sclozo. I never say it quite right. So it is another epi book. And it's basically for person time. So what we have here, right, is a graph showing 10 people who are enrolled into a cohort study. So they're being followed over time. What type of cohort study would this be? What do you guys think? Probably a dynamic, right? They're enrolling people at all different times. Right, so you've got this first person. They get enrolled in, is that November 2004? 1 month later, they die, okay? Second person here is enrolled January 2004, and is that April of 2005, that person dies. Okay, so you're following these people forward to death. But you have this other thing right here. C stands for censoring. That means that somebody was withdrawn from the study. Okay, so you were watching them, and they left for whatever reason. Maybe they said, I don't want to participate in your study anymore. Maybe you decided you shouldn't have them in the study for certain reasons. Maybe they just up and disappeared and you don't know what happened to them. Okay, so that's censoring. So you'll count that person until you record them as either withdrawn or lost to follow-up. Okay, so another way, so this is looking at when the person enrolled. Okay, and you guys should be familiar with these type of graphs because they certainly will appear on the problem set, I think, and on the exam. All right, so you can push all of those people over to the start, okay, and just count up the number of months that people were in. So it's the same graph, right? Now I've just put everybody at 0, okay? That's month 0 of when they were enrolled in the study. And that makes it easy to actually count up the amount of person time that they're contributing. So if you do that, so we've got person 1, right, 1 month. Person 2 gets, 15 months? Oh, no, 17 months, yeah. Person 3, 20 months. It's nice that it's actually already on there. Person 4, 9 months, etc. Okay? Person 5 is the only person that was in your study for the entire time that did not either die or leave your study. Okay, so they contribute 24 months of time. Okay, so you can do this, right? And so you take what each person, here are the months, okay? And you can even divide it down by year if you wanted to say the incidence or of the mortality rate in your study in the first year versus the second year, okay? So you can add up the total person time. So the follow-up period, right, here, they're followed for 1 month, 1 divided by 12, 0.083, right? So that's the total follow-up period. Yep. Okay. And that's how you add up the amount of person time that somebody was observed for. Okay. Yes. Yeah. So this is just showing, like, I could also ask you on a test question. I could say, okay, in the first year of the study, what was the incidence of death? In the second year of the study, what was the incidence of death? And what was the overall incidence of death? Okay, just to show you how you break that down. Okay, so for person time, all right, it could be 1 person followed for 1 year, right? You could follow 2 people for 6 months, 6 people followed for 2 months, okay? 1 person for 2 months, 1 person for 7 months, 1 person for 3 months, all without disease. I could go on, but that's the basic idea.
Back to the other slide.
Yes.
So, like, for example, person 1 was followed for 1 month. But when you look at the whole study, 2 years, that's not reflected. It's only assumed that it's only 12 months.
What? No. Sorry.
Sorry. So you have the first year, you have the second year, and even the total follow-up, which was a 2-year study, there's quite a few people that didn't get counted in the second year. Only have the value of the first year, even though it's a 2-year study.
Yeah, that's correct.
Why?
Because that's the total follow-up period. So over the course of the 2 years, like,
That person, for example, 1 month, the person died, but it was a 2-year study. So wouldn't that count as 1 over 24 at the end? Certainly for the first year.
No, I see what you're saying. No, because I'm turning it into a person year. There are not 24 months in a year. There are 12 months in a year. I could also do person months, right? So then I would just move all those numbers over, right? I could do person days and multiply everything by, something, by the number of days in a year. 364.5, I think, is what we use in EPI. But do you see what I'm? Yeah.
I see what you're saying.
Okay. So it's kind of going back to this, right? Where 1 person year is, you're dividing it by the total number of months here. But it could be any different combination of people. And the thing is, like, in EPI, we think of that, 100 people followed for 1 year is the same as one person followed for 100 years? Is that really the case, though? Probably not, right? So that's one of the things that we do typically do quite a bit, though. Okay, so in cohort studies, you know the amount of person time contributed by each individual, or roughly. Okay, if you lose them to follow-up, you may not know the exact moment that they disappeared. And so you can calculate an incidence density rate. One problem with a cohort study is sometimes it's not very representative. Okay, I want to study dengue fever in children in Nicaragua, and I enroll children in one area of the city. Okay, that doesn't mean that their experience is representative of every child in Nicaragua. But you publish it and you say that, and maybe you even say that this is the experience of children in Central America in general, right? And we will use those rates for that. And so there are various forms of bias that can be involved. There's also quite a bit of selection bias. People who agree to participate in studies may be different than the average person in the population. All right? And we will talk about selection bias later on in the course, so you don't have to worry about that too much right now. Okay, so that was incidence. Another measure that we're concerned with in EPI is prevalence, okay? It measures the frequency of an existing condition or disease at one point in time during a given period, okay? So you've got now prevalence, right? We'll leave the equation up here. All right, let's get rid of new. There's no new there anymore. It's just the number of cases. All right. Population. Okay, so you guys will learn that my handwriting is terrible. Okay, so cases of disease divided by the population. It's a measure of disease status. Is the disease present or not? Okay, so it doesn't depend on a new case of disease. And there are a number of factors that influence prevalence, okay? Disease occurrence, the incidence. The higher the incidence, typically the higher the prevalence, okay? Duration of illness, the longer people live, even if it's a low incidence, okay? You're going to have a higher prevalence. So it's a good measure of disease burden in a population. And it's often used to measure diseases for which is difficult to determine the exact onset, okay? So MS, asthma, diabetes. Because if somebody comes in and gets diagnosed with diabetes today at a doctor's office, do you know when they actually, did they get diabetes this year? Last year? It can be quite hard to say. All right. Birth defects is another thing that is typically we use prevalence for birth defects. And so it's the proportion of congenital malformations among all live births. Okay? And the reason we use prevalence for birth defects is it's very difficult to ascertain the proportion of embryos at risk for a birth defect, right? Because many pregnancies end before it's detected. And even if it doesn't end before it's detected, many miscarriages are not reported. All right. Okay, so here's just one example for spina bifida, right? Looking at the trends. This is just in the U.S. comparing Hispanics to non-Hispanic whites and non-Hispanic blacks. As you can see, it's generally decreasing. Spina bifida, do you guys know what that is? Right, neural tube defect. Yeah. All right. So there's a relationship between prevalence and incidence.
If prevalence is related to incidence, why is prevalence better for situations where you don't know how to?
Because you can't say that it was a new case. So incidence, it has to be a new case. You can say you can say, which is kind of awkward, the incidence of diagnosed asthma cases, okay, because it was the first time the kid was diagnosed with asthma, but you can't say that that child actually became a case of asthma, an asthmatic at that particular moment in time. It might have happened last year, and the parents said, oh yeah, they were wheezing last year, this happened, but I wasn't too concerned until they had a full-on attack, right? So this is kind of simplified, or definitely simplified. Okay, so prevalence is equal to incidence times duration of disease. It's only true if the population is in a steady state, so the incidence isn't really changing very much, and if the prevalence is low. Okay. So the reason for this is, I think this is what's always taught in this course. But the true equation, which you don't have to know, but I'm going to show you anyways, is prevalence is equal to incidence. Wait, there we go. Right. Incidence times the duration of disease over 1 plus incidence times the duration of disease. Okay? And the reason for this is that prevalence is what? So rate, ratio, proportion. It's a proportion, right? So it's going to be between what and what? 0 and 1. Okay. So it's going to be somewhere between 0 and 1, but incidence is a rate, and so its value is 0 to infinity, right? And duration, probably not infinity, right? Because nobody lives for an infinite number of years. But duration could be quite long, 0 to 100 or something. And so then you would get a number that is more than 1. Okay. All right. But for the purposes of this class, prevalence is equal to incidence times the duration. Okay. So what disease would have the highest prevalence? A disease with low incidence and a long duration of illness, a disease with low incidence and a short duration of illness, or a disease with high incidence and a short duration of illness? What do you guys think? Okay, raise your hand if you think it's the first answer. Raise your hand if you think it's the second answer. Raise your hand if you think it's the third answer. Raise your hand if you're not voting because you don't think it's any of the answers. Okay, that is correct. It was a trick question. What if I asked you the other question? Which disease would have the lowest prevalence? First answer? Second answer? Third answer? All right, correct. So low incidence and short duration is going to have the lowest prevalence. Okay, so this is looking at prevalence and the relationship with prevalence and incidence and duration of disease. An example from Brooklyn of acute and chronic leukemia, okay, 1948 to 1952. Just thinking about acute leukemia versus chronic leukemia, which one's probably going to have a longer duration? Chronic, right? Chronic leukemia. Okay, so we can take this example and calculate incidence. So we're looking at 1950 in particular. I just picked that out, right? Okay, so we have 83 new cases of disease. And I am missing a 0 on the bottom here, but it should be 2,525,000 people. Okay, I will correct that before I repost these slides. Okay, so you take the number of new cases divided by the population. We just assume everybody is at risk, right? Because we don't know who has already had leukemia in the population. Multiply it by 100,000, and you get 3.3 cases of acute leukemia per 100,000 population. All right? We all good with that? Okay, so this is what type of incidence measure? Per 100,000 population per year. So this is an incidence density rate. Okay? So prevalence, okay? We're going to take the number of cases that are still around from last year, add them to the number of cases that we have this year, and then subtract the number of deaths. For the purposes of this question, we are assuming that all the deaths happen before you're actually taking your one measurement of what's happened in the population. Okay? So divide that by the total population, and you get a prevalence of 0.9 per 100,000 population. Okay? In this case, the incidence is higher than the prevalence, and why is that? It's acute, right? It's got a short duration of disease. A lot of the people who got it died, right? There were a total of 100 cases in the population that year, some who survived from last year, some who were newly diagnosed that year, and 76 of them died. Okay. Now we're going to switch and look at chronic leukemia, all right? So we have 90 new cases of chronic leukemia, okay, who were diagnosed, and once again, missing the 0. Divide that by the population, and we get an incidence rate of 3.6 per 100,000, okay? Very similar to the last one, right? But when we look at the prevalence, however, we get a very different number, right? 6.0 per 100,000 population, and that's because the duration of illness is longer. So, using that equation, okay, you can actually figure out the duration of illness. So we just do a little bit of switching, right? So duration of illness is equal to the prevalence divided by the incidence. So for acute leukemia, you get 0.27 years. So we're taking 0.9. That was the prevalence divided by 3.3. Okay? And that gives you 3.3 months. Do you guys see that? Is there confusion? Raise your hand if you want some clarification. No? Okay, we're good. All right, so for chronic leukemia, same thing, but you get a duration of 1.6 years, 1.67 years. Cool. Yes? It was per 100,000 population per year, and the prevalence was per 100,000 population. Okay, so then you get years left over. The calculation of the incidence was per 100,000 population per year because it was only 1950. It is considered an incidence density rate. Yeah. We'll go. You guys will go over that a little bit more in section. I am actually running way behind, so I apologize. I may not finish this. So there are a number of sources of data for morbidity and disability. So you have disease surveillance and registries, surveys, cohorts. Okay, surveillance, according to the CDC, is the ongoing systematic collection, analysis, and interpretation of health-related data essential to the planning, implementation, and evaluation of public health practice closely integrated with the timely dissemination of data to those responsible for prevention and control. Okay, kind of a complicated definition, right? But basically, surveillance is you collect a lot of data, you put all that data together, you do analysis, you generate a report, you actually get those results out to the public and to policymakers, okay? And those reports and what comes out actually will then go on to affect data collection. Okay, so this is just an example of surveillance in California, 1995 to 2004. What disease is this? Chickenpox, right? So you see chickenpox had a very seasonal pattern. What happened right around here? What? Vaccine, right? Vaccine, the number of people with that vaccine hit a certain level, and the disease became much more controlled. Okay, this is another example, just pertussis. So you see a sharp decline going into the 1970s. We're a very low rate of pertussis. We are currently having a pertussis outbreak here in California. All right, and you've had this upswing of the number of cases, and that has led to a recommendation from the CDC that all adults get what? A booster, a pertussis vaccine. All right, so you can calculate incidence, which approximately equal to incidence density from surveillance data. That's what we were doing when we said per 100,000 population per year. Okay, so there's underreporting, which would lead to underestimate of cumulative incidence for many diseases. Okay, you're never going to detect all the cases in a population. And there can be variations in the completeness of reporting and the accuracy of denominators, okay? Things like race, SES, yes?
So in the reports from like the World Health Organization or the UNAIDS, there's
Mm-hmm.
So is there?
So it's a little bit outside of this course, but there's a method called capture recapture, and there are several other methods, and you can calculate these things called multipliers. So you figure out for every one case that's reported, there are 143 cases that aren't reported, right? For HIV, the multiplier is much lower because it's much more likely to be reported, but that's how they do it. And you can calculate the variance on that multiplier and thereby get a 95% confidence interval. So that's how they get those ranges for the WHO. So disease surveillance, it's legally mandated in each state, okay? Most reportable conditions are infectious. So here's just a quick list of nationally notifiable diseases in the United States. And as you can see, we've got cancer here, which can be infectious, but not necessarily, right? And then lead exposure, but I think everything else on the list is an infectious disease. Okay, so another source of data that epidemiologists use a lot are registries. Okay, so for example, there's the Surveillance Epidemiology and End Results Program, SEER. Okay. Another example is the birth defects, the California Birth Defects Monitoring Program. So just quickly to show you, SEER would collect data on a number of cancer outcomes. Here we can see the incidence of gastric cancer between 1973 and 1999. It is decreasing. Okay. One reason for that is we actually figured out that it can be caused by Helicobacter pylori, that we should treat ulcers, right, and prevent gastric cancer. California Birth Defects Monitoring Program monitors a number of different birth defects. Okay, here we've got rates of neural tube birth defects by mother's age. You don't see a big difference, but you do see that people who are younger tend to have higher rates of neural tube birth defects. Why do you think that is? So what is one major risk factor for neural tube? Yeah, so deficiency of folic acid, probably a lot of people here, the younger age group may be having unplanned pregnancies, whereas there are more planned pregnancies amongst the 35 to 55-year-old group. Okay, just looking at another birth defect, right? So chromosomal defects, mother's age. Here we see a sharp relationship between mother's age. The older you are, the higher your risk, right? So for examples of surveys, there's the NHANES. It's the National Health and Nutrition Examination Survey. It's a random sample of the U.S. population. National Health Interview Survey, 40,000 households in the U.S. is meant to be representative of the U.S. And another example, and these are all in your book, is the Behavioral Risk Factor Surveillance System. It's a telephone health survey system. Data is collected from all 50 states. I've actually gotten a call from these people one time, right? So they call you up and ask you a few questions about what you do, basically. Okay, so for NHANES, one of the things that they collect data on is hypertension. They collect data on race, and you can do you can look at a number of different things. It is a survey. What are we going to be measuring with surveys typically? It's even on the slide. Prevalence, right? Prevalence. All right, so behavioral risk factor survey. This is data on obesity in the United States. Here we have 2000, 2005, 2009. If you go into blue or black, that's much worse. What can you conclude from that? Is the incidence of obesity getting higher or the prevalence? Prevalence, right? This prevalence. So the prevalence of obesity is increasing in the U.S. There's just a report out, I guess, that actually said that part of the reason for that in women is that they don't want to mess up their hair, which I have yet to read, but somebody emailed me about it this morning. And so I'm wondering if actually that comes from this system. I'll have to figure it out. Okay, so there are a number of limitations for surveillance data. Numerators, okay. Disease reporting is often incomplete, okay. And it can vary by disease, region, race, age, over time, all right. older people more likely to have health insurance, therefore more likely to be a detected case than a younger person who says, I'm just going to stick with this disease, stick it out, suffer for a week in bed. And individuals may be misclassified in terms of race. Okay, in the denominator, we've got the U.S. Census. Okay, some groups are undercounted. Completeness may vary geographically. And there are also years between the census, and so we have to just do estimates of what the population is. We are actually doing okay now. So AIDS and Native Americans in Los Angeles and Seattle. Race which is most commonly misclassified are Native Americans or American Indians. Okay? So 6 out of 8 Native Americans with AIDS were misreported as white or Hispanic in Los Angeles. Right? In Seattle, 5 out of 6 Native Americans with AIDS misreported as white. And 4 out of 4 death certificates for Native Americans with AIDS misreported as white. Okay? It's also a population with a smaller denominator, right? So that misreporting is going to affect rates a lot more. Okay, and this is just a slide showing that that's not just in AIDS, it's in a variety of diseases, and that they can, that Native Americans can be misclassified as white, black, Asian, Hispanic, or potentially other unknown. And that is it. So I'll be around for a few minutes if you guys have any questions. Sorry it was rushed at the end there.